Okay. Welcome, everyone. Thank you for coming to today's seminar. Today, we have the pleasure to be joined by Dr. Abderrazek Zeraii from the Higher Institute of Medical Technologies in Tunis, Tunisia. And he's a neuroimaging scientist, and he will be talking today to us about arterial spin labeling as part of the 2024 SWiM program, so that we get a better understanding of advanced brain imaging techniques. Yeah, we're excited to hear what you have to say, and whenever you want, you can start.
Thank you very much for this wonderful introduction. I'm happy again to be with you for the second years. So today I would also to thank you, the organizer, for the SWiM program inside the middle and low income country inside Africa and South America and South Asia. That's very fantastic program. That's maybe we can put our all of efforts to gain and to enhance and to promote for technologists and radiologists to maintain and to understand the physics of MRI and the application of MRI. Today I will talk about the arterial spin labeling with Philips machine, the acquisition, also the post-processing, and also I will talk about the functional MRI with bulk contrast, blood oxygenation level dependent. So I will start. So arterial spin labeling, it's used to quantify and to assess the supply of oxygen and the nutrient inside the brain and to see the perfusion we have through the cerebrovascular system. And we have multiple choice to do the arterial spin labeling through the pseudo-continuous arterial spin labeling, also through the multi-phase star. Also, we have the time resolved angiography angio that's dedicated to see the circle of Willis, as called cinema. So the arterial spin labeling is a sequence that is basing on three different parts or elements. We start with the labeling image and the control image, and we have also the delayed time or the post-label delay, and also for the acquisition time or the acquisition image. So it's a method that is based by the subtraction and the averaging of different dynamics. Maybe you can go to 40 or 30 dynamics by applying different types of control and label imaging through different dynamic to get the perfusion data. You see here just to add the control imaging and go through the label imaging to add them together to have the perfusion. So by applying different labeling delay plus the phase interval, we see the different particle or different part of the brain to go from the carotid to go to the circle of Willis. So this is the technique. We apply a delay or for the labeling image and to join with a phase interval phase in different parts or different dynamic to get this image. The labeling method, as I said, we have three different parts. We have the star, we have the pseudo-continuous arterial spin labeling, and we have the cinema one. To start with the star one, we have the label gap between the label and the image, as you see in the image, and to see the direction of different spin on different momentum. And it's a little bit different between the pseudo-continuous arterial spin. It's based with a big difference between the label image and the control image. So, and that's the momentum or the magnitude of the blood. It's different. There is a difference between the magnitude blood inside the control image and the label image. or the planning of the image. We have, for example, here an example of a sagittal planning of the posterior cerebral artery that we can use the pseudo-continuous arterial sprinkling as a labeling plan. And we can apply the time-resolved angiography to see the circle of Willis in different axial, in different view, like axial and coronal and sagittal view. So the ASL perfusion imaging, it's a very sensitive technique. The labeled imaging, the labeled blood imaging, which is the label image, only it's represent 3% of the signal content. Sorry. Okay. With background suppression, this is here with the green one. As you can imagine, physiological variation between the label and the control image can be in the same order of the magnitude as the direction. So if you do a subtraction, it results in an image that is encoded for not only perfusion, but also other physiological difference. Background suppression aim to minimize the effect by making sure that there is less background of signal as possible, one to avoid the contamination. It's not an arrival to suppress the background suppression. We have the aim to minimize the signal of tissue with a range of T1 in a second, which can be done with the multiple background suppression on the labeling, the duration also, and the post-label delay. In practice, they also need to fit in the post-label delay. You see here the brain tissue, and by applying background suppression and the variation to see the accusation. Yeah. So this again a little side setup that's relevant for all dynamic API study. So mainly maybe you can use it in functional MRI. Also here for the arterial spin labeling, the theoretical optimal spear facade offset at 3 Tesla is 2200 Hertz, because the fat peak is 2000 hertz away from the water peak, so it's not more accurately, so it's a bit dangerous to put the water. So the problem that is caused is pulsating or off resonance of cerebrospinal fluid. Sometimes gets suppressed and sometimes not. We can see the results in the dynamic image. This now we are talking about in terms of acquisition, the single spin labeling also versus the multi-phase one. So the single phase we can use 2D fast field echo by the echoplanar imaging one, and for the pseudo-continuous arterial spin labeling, we can use also the same sequence by applying the fast field echo through echoplanar imaging. For the multi-phase, we can use in star image the 2D fast field echo imaging through the API. And for the star angio, maybe we can apply it's a new sequence through inside Philips, which is called the 3D turbo field echo by applying the echoplanar imaging. The first for single phase, maybe you can maximize the ratio of signal to noise by applying redoubt, or just if we can get to do the same like when doing the cardiac session by applying the loop locker to find a small time of inversion and to have some redoubt. So this is also to image. That's we differentiate between applying 2D imaging through API by a single shot and the multi-shot by applying 3D gradient echo and spin echo the same. That's I'm talking about in the 3D turbo field echo through the coplanar imaging. This is an example that we have applied the turbo field echo. We have here just a signal loss, and also in the same image that we have here, just a little bit of noise or artifact. It's called NP gust. So in the user interface, we had to apply or parameter different phases by parameter multi-phase acquisition, and through the motion we push or to make sure that we have applied AS in the multi-phase ASL. Also to define the number of the phase, maybe we can go through 8 phase or more ever. The phase interval or the delay, it's 2050 millisecond, and the cycle duration, maybe we can go through the 40, 100 or 4,000 millisecond. The heartbeat, just to be make sure it's not realistic, or to make, maybe you can put it now for also for the slice following, and we can also we can't use rest right or rest slab. For there is no need to use the compensation of respiratory compensation by the PPU or the ECG. So also for the dynamic, just to make sure about the parameters that we used, just the dynamic scans, maybe we can go through 30 dynamic scans. You see just the mode here for the arterial spin labeling. You can modify, as you know, by star or pseudo continuous or cinema, or just make sure that this parameter is dependent on your package that you put inside the acquisition. So yeah, this is the phase, this is the mode, this is the parameter that you can use it. This is the duration between the delay and the control image, and you can repeat through different dynamic. So we can maybe we can use the arterial spin labeling not just for the acquisition or to see, maybe also we can use the pseudo continuous ASL for the quantification. It's a new sequence. That's by applying 2M0 or just for the first dynamic, and after that we can maybe apply between 2 to 8 dynamic to measure the cerebral blood flow through this equation, mathematical modelization. And this it was recommended as through the ASMRM perfusion study group and the European Consortium for ASL in Dementia, and what it was used as a new sequence to quantify the blood flow. This also for the data processing. Maybe we can automate it in the reconstruction by applying the first series for the perfusion and the angio image. And we should make sure that we have applied for the normalization on the image by AS to quantify the cerebral blood flow, to quantify in the processing data. And maybe we can do the reconstruction inside the inline or inside the machine or the window of acquisition. And the same, the second series would be as an optional source data. So this is the interface. So just we can modify or of course, there is a different release in Philips between release 5 or release 4 or release. Now we attend just release 5.7. Even there is a release for the new system for the Ambition X and the Ambition S, also for the addition to the release 11 and a release 12. So there is different release, and it's dependent when you do some post-processing, it's dependent on the release that you have. The basic one that you can modify the image that the color of the image to see the quantitative image to see how many milliliter per 100 gram per minute as to quantify the cerebral blood flow and to see the perfusion inside the image. So there is here to see different image through applying the pseudo-continue ASL into 2D for the coplanar imaging and also for the 3D by applying the gradient echo and spin echo. So there is not big difference in terms of post-processing, but it's a little bit different in the term of acquisition because it depends of the signal to noise ratio. Also, the time of acquisition is a little bit different when we work on 3D than 2D. We have also, for example, just this case, which talked about the pseudo-continuous ASL to DAPI and 3D grass to see just the difference in terms of the color and also the mapping. So this is the part of pseudo-continuous ASL and arterial spin labeling. Just in this part, don't hesitate if you have some question to send me or through the chat box. If you have a question now, just ask me. If not, I will pass through the blood oxygenation level dependent and functional MRI. I don't know, just if you have a question now or just when I finish the second course and the second materials to discuss a little bit.
Do you
I don't know,
mean?
Marina.
Yes.
I have.
Do you mean yes? Continue, sir.
Yes, I have the other second part of the course.
So you're going to do that now, or?
Yes, if there is any question about the arterial spin labeling one, I will interact with the audience. If not, I will pass through the blood fMRI and we will discuss all the two parts after the. I don't know.
Okay. Any questions?
Hello, good evening. Time for the presentation. I think I have a simple question. I'm told 3D ALS is a luxury sequence. How true is it? As in, if you have a 2D, you can equally do the job. So you acquiring a 3D ALS software is like it's luxury, if I put it lightly. What are the advantages for the 3D over a 2D?
Yes, that's a good question. I think that's like all the image or like all the sequence for example, when we talk between the 2D or 3D, just maybe we can go 3D different slice, other slice like coronal or sagittal or axial, and by using that's by using equiplanar imaging. Can have this 3D even in 4 or 3 minutes, for example, in time of acquisition, and maybe after that we can do the reconstruction in different slices you want. And for the 2D, of course, just maybe you can have one slice like or one orientation like sagittal or axial or coronal in 2 minutes or 3 minutes by different time or by different parameter of acquisition. So this is the difference. And other difference is the in 3D we use the gradient echo and the spin echo. It's combined technique. But in the 2D, just we use the gradient echo. Yeah. I hope
Okay,
that
so
I answered your question.
that makes a lot of sense. So, but acquiring that software on a Philips scanner. I'm using a Philips scanner. Is the price difference that huge? Because I don't currently have it. I don't have the ALS. So I'm pushing for management to buy the ALS software. So since what I know that the 3D is a luxury, what's the price difference between the 2D software and the 3D software? Or is it one packet that when you buy, you get both?
You know, that's the ASL, even 2D or 3D. 3D, the package of 3D, it's an option. It's not basic inside the MRI machine. So this offer you, like I said, the quantification, for example, for the cerebral blood flow mapping card. And so, yeah, it's an option. It's not basic inside the machine. And this is one by the difference that you have.
Okay, thank you.
Yeah, thank you.
Sorry, if I may ask again, you mentioned that the ALS is a basic sequence in the MRI scanner. I'm using Philips 1.5 Ingenia Omega. I think purchased like 3 years ago. Will I have the ALS software? Does it come as a preset, the default sequence in the scanner, the ALS? Because I don't think I've seen the ALS software.
I think that the software there is, you talk about the post-processing.
No, I'm talking about the ability to use the sequence, get the sequence to scan. Not the post-processing, the sequence to scan.
Yes. And which release you have inside the machine?
5.7 or 5.4. I can check for you before the end of this presentation.
Yeah.
So you go ahead.
Can check.
You go ahead. I'll get it for you right now.
Yeah. Okay. Nice.
Thank you.
Just I will interact with you later, maybe through WhatsApp. You have my number. Maybe Marina will provide you all my contact. And through the SWiM program, we try to maintain this relation, and we keep, especially because I'm specialized in Philips and work with Philips. So if you have any problem, any issue inside the accusation, or even for the post-processing in different area, for example, we're gonna be talking about the functional MRI and the iView board, which is dedicated for the post-processing for the fMRI of bold data inside the Intel space for Philips. And also for the other users like Siemens or GE, maybe we can see how we can fix the parameters or to put the parameters inside the machine. Maybe we can talk and to fix the problem. So yeah, for Philips one, just you have my WhatsApp and my mail, and maybe we can contact after this meeting or in the next few days to, if someone of you they have a problem inside the accusation, maybe we're talking to fix it. Yeah. So I hope.
Thank you. I'll do that.
Thank you, George. So now just let me share the slide. Wait. Just wait. Yeah. Sorry. That's fine.
Yeah, we can see it now. Yeah, maybe we can share your email address in the chat for everyone interested.
Yes.
Okay, I'll put it in the chat.
That's clear?
Yes.
The session, yeah. Now I'm talking about just to keep in your mind, because even ASL or functional MRI is a little bit big area, and maybe we can talk about it through different parameters, but I give all the necessary just in terms of acquisition and post-processing. So let me check with you and give you an idea about the functional MRI and the contrast body. So just to remember that all start with hydrogen, like the magnetic dipole momentum, and the orientation with the same, that's talking about the physics and also the orientation of this magnetic dipole moment through the B0, which is aligned with Z, which is aligned also with the parallel to the Z axis inside the Bohr machine. So it's really to measure the time of relaxation that you know, T1 relaxation. There is also the T2 relaxation, and there is the T2 star relaxation. The T2 star relaxation is really that's affect the blood contrast. The main objective that's about the blood oxygenation level dependent is to measure the homogeneity in magnetic field, which is the change in the level of oxygen inside the blood. So it's a relation between the magnetic blood and not magnetic blood, which is called the magnetic blood. It's the deoxyhemoglobin and oxyhemoglobin, and which is a relation that's it's blood oxygenation contrast. It's a measure between oxyhemoglobin pair to sum together the deoxyhemoglobin and the oxyhemoglobin contrast. And to see here, that's the normal flow, which is a high ratio deoxyhemoglobin, which is an oxygenated blood that gives us a fast decrease in MR signal. And here the oxygenated blood, which is a low of ratio between in the deoxyhemoglobin. You see here the red balls, it's a little bit, and in terms of quantitative, so they give us a slow decrease in MR signal. So we can use the change in functional MRI signal to infer the relative oxygenation of the blood. So what's the cause of BOLT, which is the blood oxygenation level dependent? The purpose is of the increase in blood oxygenation is to feed neurons. So what makes a neuron hungry? You know that the blood and the brain consumption in terms of glucose, in terms of blood, it's around 25%, and you know, it's just to keep in your information in your mind. That's the mass of our brain. It's 2% to 3% of our brain, of our body. So the consumption of oxygen, the consumption of nutriment, the consumption of glucose, this is what make our neuron need oxygenation. So this is the physiology, the hungry brain, that's they need always the oxygenation. That's the pump that, you know, in biophysics, that the change between the potassium and the sodium. And you know, that's the presynaptic neuron. Always there is an exchange in terms of biophysics to have a signal when we have the postsynaptic neuron. 50 to 75% of energy use in action potential driven. It's a reminder is on housekeeping, just in terms of consumption. And also the most of energy is spent on the uptake of glutamate and reversing the ion. Considering the neural activity, but it's a little bit complicated because no easy relationship going from the neural activity to BOLD. The relationship cannot only differ between brain area. For example, we talk about the cortical area or occipital or frontal or temporal lobe. It's a little bit complicated to understand what can happen inside this area. So the relationship cannot only differ between brain area and the level of activation, but also between subject, because there is subject one different, it's not, there is a rule in terms of consumption between subject one and subject five, for example, or the amount of quantitative of in terms of consumption between subject one and subject five in terms of the localization and the amount of the consumption. So what we can understand from it, it's no summation of both signal, no directly comparing different area, because different vasculator, different neuromodulatory control, there is a different circuitry. So to keep you in mind, for example, to differentiate or to compare between two subjects X and Y, the bald of X different superior to the bald of Y doesn't mean neural activity X superior to activity to Y. That's the rule. So what does a blob in area X mean? X has changed its local activity, and this changement also is required of all the inputs that's arriving at the X area. So what's this mean? This means that's when we talk about a local activity, it's dependent of this area. And all this change in this, for example, the cortex or the temporal or the vision area, it's all these changes, it's all of this input inside in terms of consumption of oxygen and consumption of nutriment and in this area. So this is what a blob in area X mean. So other way to measure the neural activity, for example, it's by applying different stimulus, for example, by moving eyes or just by thinking in different block diagram, or just to move a little bit of our fingers. It's called the stimulus. Our technician or our radiologist give different in terms of vision or on terms of movement or motion or different action. It's called stimulus or paradigm of stimulus that's given to the patient, and to modify a little bit by differentiating in terms of time, and to see the different compartment of the blood signal. Yes, just this image, it's get from our scanner. It's release 4, and to see inside the Philips database when we can find the blood imaging and we can find the sequence. So we go through the brain and the blood imaging, and also to find all of these different sequence. Maybe we can you can have the ability to choose between different scans, but the important one is to have an inversion recovery for as a reference one. And also maybe you work with the fast field echo with API, or the sequence echo with the API. Also, you can choose the T1 weighted 3D turbo field echo as a reference one. So you have the ability to choose this one or this one. And the sequence, maybe most of people use the gradient echo with the echoplanar imaging. So this is just an info on the T1 weighted inversion recovery as a reference one. It's T1 weighted inversion recovery based on sequence. It's a reference scan for single shot fMRI. Just to use it, we have different parameters. We use just shortest FTR. It's very significant for relaxation of all the tissue magnetization. Also, maybe we can use 3500 millisecond to obtain this a good T1 contrast. Try to use to minimize to use a short TE in order to minimize the T2 whitening. And also maybe we can use in terms of fat sat or saturation, maybe we can use the spear because we use T1 contrast. Also for the reference, you can use the T1 3D turbo field echo as a reference one, which is a T1 weighted imaging 3D gradient echo based sequence as a reference. Maybe we can use time of inversion in a range between 800 and 1100 milliseconds to get T1 contrast, a good T1 contrast. In terms of voxel resolution and maybe we can use isovoxel. The best orientation is the sagittal orientation, but here we're working with 3D, so maybe we can do the reconstruction in different way. This is used especially for the eye view ball because we have the post-processing after the acquisition. And this is the Feed Eco API. No, this is the dynamic T2 star, which was used with different paradigm, for example, for the visual, for the movement, and for thinking, for talking. Different radiologists or scientists, they give us some paradigm to understand what mechanism inside the brain maybe you can work with. So this is the image. Maybe you can working with the feed echo sequence or the spin echo sequence. This is also another sequence which is a field echo API with high resolution. It's a little bit different with the classic one, but this is give us in terms of signal to noise ratio. Also for the parameters, they give us high resolution and to minimize a little bit of the artifact. So this is the spin echo API. It's a little bit long than the gradient echo, like everybody, that's when you're working with the gradient echo is to minimize the time of acquisition than the spin echo acquisition. Here I try to give you just an example that's we used for the motion activation. Here we used fMRI single shot. The single shot acquisition is it's for 15 to 20 milliseconds in terms of acquisition. There is this different parameters for all the radiologists or the technician that use Philips machine. That try to use the FOV that like basic brain and try to use TE short TE to minimize the T2 effect, to orientation, and the lentier it's not. And here maybe you can number of excitation or number of saturation. It's maybe you can use 1 or 2. It's dependent of the time of acquisition, and it depends of the reference signal level. Should be around 100% or 99 or 95% to have a good signal. Also here for the geometry, maybe we can follow the uniformity. You can put it as clear. For example, you have your FOV. The voxel size, it's around 3.4 or 3.5. It's good orientation, posterior orientation. Also, the slice thickness, maybe you can work with 4. The fold over, there is no need to use the fold over direction. The reconstruction matrix also in 64. There is no need, for example, here to use the sensitivity of encoding to minimize the time of acquisition. The stacks also, maybe you can use 1. The slices go through 25 or 30. It's dependent on your brain that you scan. Here for the contrast. So make sure that we talk about the fMRI single shot, that you use the technique of fast field echo. with a fast imaging mode, echoplanar imaging. Make sure that you don't use the turbospin echo. Also, it's a single shot. The number of echoes also we can put 1 TE 50. The angle of flip, it's go to 90 degree, because maybe you can have the T1 because it's a little bit like you have T1 contrast. Also, there is no need for the half scan. The shimming, try to put it automatic. There is no MDXON also for this, and the fat-sat separation, we can use the speed one. For here, inside the motion, there is no need for the cardiac synchronization, no need for the respiratory compensation or navigator respiratory. For the flow compensation, also there is no need. And the number of excitation, it's dependent on you. If you want, for example, a good signal, maybe you can use 2 or 3, but the term of scan is a little bit high term per acquisition, because you have a paradigm. For example, if you work with a motion, you have, for example, paradigm that 30 seconds to activate, 30 seconds for resting, 30 seconds. So if you use a number of excitation more than 1 or than 2, maybe you can have a conflict in terms of to do the paradigms, and you don't have a good paradigm. So this is, I'm trying to do the post-processing inside the IVU bolt. So here the image that we have, the different paradigm here, rest motion, rest motion, rest motion, through different time. And here maybe we can use to select the paradigm. I have a video after this slide that's talked about the post-processing. And maybe here, maybe we use the anatomical series that, like here, we use a 3D T1 turbofield echo reference with sense. It's with sense to see the different activation in different area. So just I have a video for you, this one. So we use a block paradigm with just to set the smoothing with a little bit to check also the patient motion here, different slices and different amplitude. This until space 7 for MRI view board. Also to choose the paradigm, hand or visual or language, which one you work with. To apply default mask, also to suppress motion related artifact, and to compute to see the different area. And here maybe you can select anatomy for underlying. For example, you see here. Yes. So here to show the time intensity display in different region, and we have a score for the brain activation area, and to have an idea about which area it's already function or already activated. So this is an overview about the MRI view bold tools for the post-processing of the bold imaging and functional MRI. This is a little bit, I give the little bit of parameter that we can use inside our machine. It's dependent of our system. You know, that's with Philips, there is a different of type of machine. And also, for example, there is the difference also in the gradient system that used. Also in the IntelliSpace portal, there is the 7, there is the 9, the 10, also we have 11 and 12. Also there is the advanced workspace, which is Philips IntelliSpace 15. That's as launched this year. So these advanced tools for neuro post-processing data, it's very important today. I don't know which system you have, but this is the basic for the acquisition, and this is the tools for the post-processing. So Hope you enjoying this session. Hope I give you the essential of our work of ASL and also for fMRI Bolt. And my all ears for you just to answer of some question that you have. Thank you.
Thank you very much. If someone has any questions, please unmute or write in the chat, and we can see. I have a question in the meantime.
If you don't have a
talked
question, I have a question for you.
Yes. No, so you talked about some wide range of fMRI sequences, and I'm not very familiar myself, so I wanted to know what it depends on which one you would use. So how do you choose which one is the best for you?
Yes, usually for time, like just we have the T1 as a reference, and we have the 3D gradient echo for the reference. This is what we use to underlay in the image. So, but when we use in the paradigm, when you use different paradigm like language, like motion, and like talking. So we use the fast field echo with the echoplanar imaging as a fast mode imaging. So for me, and usually for the customers, they believe in the fast field echo than the spin echo, because you have some paradigm, and the paradigm it's depend on the duration in term of time, because you have, for example, the radiologist, they can try to use 10 seconds for the rest, 10 seconds for the activation. And when you use the spin echo, it's a little bit, maybe you can have a conflict in the paradigm. This is why I'm talking always about the gradient echo sequence. Yes. And the T1 or as inversion recovery for reference, or the 3D T1 for the reference is used on side the iView board, as I'm talking through the IntelliSpace portal. Yeah.
Okay, I think I understand.
Yeah.
There's another question in the chat. I don't know if you can see.
Let me check with you. Danny, I would like to ask how AI will be integrated in ASL and both sequence, and how accurate volumes will be. I think today and with Philips machine, there is different tools that applicate AI. I think Smart Speed, the new AI and deep learning inside the Philips machine. Maybe we can integrate the AI in terms of how to, in terms of accusation, how to make this accusation more fast, for example, and to have a good spatial resolution to attend 60 to 70% by the occasional one and conventional one, sorry. And in terms of also of time, maybe we can I had some example that's we working on, that's reduce the time in order to 50% in terms of accusation, and that's be great how to use the AI through the accusation. Also for the other one, Siemens has applied also the deep resolve boost inside their machine to have a good temporal resolution and spatial resolution. Also for the GE machine, they applied Sonic DL, especially in the 2D. It was perfect in the functional MRI. And yes, for all the competitor today, they have their own they have own the deep learning and the AI program to have a good temporal resolution, also for the spatial resolution. And there is also the AI inside the post-processing tools that make sense today in terms of visualization in terms of quantitative maps that are using by different competitors. Yeah. Yes. Hope I answer your question, Jamal Din.
Thank you, Abderrazek.
Yeah.
Okay, I think if there are no further questions, I will end the recording. And so, yeah, thank you very much for your time and for your dedication to the SWiM program. And we'll see you again next week for the diffusion tensor
Yes.
imaging lecture.
Just to add, Marina, to add, you have my mails, you have my WhatsApp number. Don't hesitate to contact me when you want. I have time to respond to any question that you have. Maybe I can assist with you even through your machine to have a good acquisition, also to have a good post-processing data. So don't hesitate to contact me. The next session, Marina, will be on diffusion tensor imaging, I think.
Mm-hmm. Yes.
Yes. Yeah. Okay.
Perfect. Thank you very much.
Perfect.